Thank you, Professor. And Professor Liu Jianmin has an emergency surgery. So on behalf of him, I'm very honored to meet you online and discuss about the stent assist coiling of the acutely ruptured aneurysm. So this is our disclosures. And since eyesight trial, the endovascular treatment has been the preferred therapy for RIA. At the very beginning, SAC was just for those very complex aneurysms, which were difficult for either coiling only or surgical clipping, such as BBA, dissecting aneurysms, fusiform aneurysm, and so on. Professor Liu finished his first stent assist coiling of a ruptured dissecting aneurysm in 2000. It is also the first case in China. And then we continuously explored in different types of aneurysms and different locations with different techniques and proved the feasibility of SAC. So we summarized the first 11 years experience of SAC for RIA published on radiology. This was a single-arm retrospective study with 211 patients to explore the preliminary safety and effectiveness. And it was also the largest series at that time. And the major findings showed a clinical favorable outcome was 82.9%. The 1-year complete occlusion rate was 75.5%. And the immediate occlusion rate was 45.5%. However, we did observe a relatively high complication rate of 14.2%. And we also analyzed the risk factors related to complications in detail. And we found that the aneurysm location, including MCA and A-common artery aneurysms, immediate embolization degree, and the post-operative heparin use were correlated with higher complication rate. So based on these findings, we did another clinical research and improved our clinical workflow and the treatment strategy. We will share the details later. And then we start a new prospective case control study for 3 years. We enrolled 133 ruptured aneurysms of SAC versus 289 cases of regular coiling to prove the safety and effectiveness further. And our results showed the SAC had a similar clinical favorable outcome and a similar immediate occlusion rate and higher follow-up occlusion rate and a lower recurrence rate compared to coiling only. Even more relatively complex aneurysms were enrolled in SAC group. And for the safety concerns, the results showed a decreasing of overall complication rate compared to the previous study from 14.2% to 8.3%. And SAC had a numerical higher complication rate compared to coiling only, but without statistical difference. These results indicated that SAC was a safe and effective option for selective ruptured aneurysms. And in the Chinese guideline, it reads SAC can be considered for RIA, which cannot be embolized by coiling alone. And we did a non-official survey and found SAC of RIA has been a common practice in China with an estimate proportion of 30%. And in the recent 5 years, more and more studies of SAC for RIA have been reported. So we performed a meta-analysis, enrolled 8 cohort studies. The results showed the SAC had a favorable effectiveness, but the complication rate was still higher than coiling alone. And we noticed that the results varied in different centers. So how to perform a safe and effective SAC for RIA? From our perspectives, the first tip is to select patients very, very carefully. Here are our several principles. First, as a neurosurgeon, we always try to clip those aneurysms with large hematoma. Second, if a patient is indicated for EVD, we will always perform the EVD before endovascular treatment. And third, always consider the double microcatheter technique and the staged stenting strategy for priority. When doing the SAC for RIA, we are always aware for the bifurcation aneurysms using SAC is riskier, and it is it is relatively much safer for sidewall aneurysms. So these are our concerns for case selection of SAC in acute stage. For such a wide-necked aneurysm on MC bifurcation, we use a double microcatheter technique to embolize the aneurysm with neck remnant, but with definite rupture point occlusion. Then we perform the staged stenting with additional coils after 1 month for this patient. And we reviewed 47 RIA cases in our center which received the conventional coiling alone in the acute phase and staged stenting after a mean time of 4.2 weeks. No bleeding occurred during the intervals. So we considered that staged stenting treatment, a strategy, is a preferable choice for RIA patient. The second aspect is about the conservative use of antithrombotic strategy when we do the SAC for RIA, including anticoagulation and antiplatelet therapy. For anticoagulation, before the 2010, we used systematic heparinization during the procedure and low molecular weight heparin after the procedure for 3 days, because we worried about the ischemic event at a very early stage. However, we found that the post-procedure heparin was correlated with high rebleeding rate. So we canceled the post-procedure heparin use after 2010 and only reserved the systematic heparinization during the procedure. And the present antiplatelet strategy in our center is the low dosage tirofiban with individual dural antiplatelet regimens adjusted by TEG. When we decide to perform stent placement, tirofiban is used immediately before stent deploying and is kept for 20 to 24 hours. Then a loading dose of aspirin and clopidogrel is used with overlapping for 3 hours with tirofiban, and then stop the tirofiban. The maintenance dosage of aspirin and clopidogrel lasts for 3 weeks, and then changing into mono antiplatelet of aspirin. TEG is regularly tested 3 days after antiplatelet administration for monitoring and adjusting the antiplatelet regimens. And as for the dosage of tirofiban, we also performed the study and compared the regular dose versus half dose of tirofiban. The regular dose is recommended for PCI. We found that half dose of the tirofiban had a significantly lower intracranial hemorrhage rate and equivalent ischemic complication rate compared to standard dose group. So half dose tirofiban is now the standard therapy in our center. The third aspect for safe and effective SAC for RIA is the technical considerations. Braided stent is preferred, using soft and modified coils for complete occlusion, and always remember that Semijelling technique is helpful. In our daily work, we feel braided stent has a better result. So we performed this study and published in Neurosurgery. We compared LV stent assist coiling versus coiling alone and found the numerically higher immediate occlusion rate in the LV stent group very closely to get a statistical difference. And then we compared LV stent, LV braided stent and the laser cut stent for SAC in 235 RIA patients with propensity score matching. The result showed the braided stent had higher immediate occlusion rate of 64.1% compared to laser cut stent, and with lower overall complication rate and hemorrhagic rate in braided stent group. So we think that braided stent is better for SAC of RIA. So why we preferred braided stent like Elvis? Because braided stent has higher metal coverage, smaller cell allowing smaller soft coils, fully visible, better apposition, and the better protection of the side branches. So we considered, whether modified coils were better. So we compared the LV stent with hydro coils versus LV stent with Bayer coils after propensity score matching. And interestingly, we found that no patient suffered rebleeding in the hydro coil group, which was much lower than the Bayer coil group. These preliminary results indicated the potential advantage of modified coils in SAC for RIA. As for technique considerations, we always suggest Semijelling technique for RIA embolization because it can facilitate the SAC for complex wide-necked aneurysm, and the immediate occlusion rate can reach to 77%, as we reported. The reasons why we preferred Semijelling technique, including better adjustment for microcatheter, lower rate of coil protrusion into stent, and better neck coverage. So just like this case of MC bifurcation ruptured aneurysm treatment, Semijelling technique has been the standard strategy in our center. After the 20 years exploration, the safety and the effectiveness of stent assist coiling are getting better and better. And it has become a common treatment method for ruptured aneurysms. However, there's still a lack of strong enough clinical evidence of SAC for RIA. So in conclusion, how to perform the SAC for RIA safely and effectively, we should be very careful of case selection, conservative use of anti-thrombotic strategy, and the technical considerations. So in the future, the high-level evidence is still needed to validate the SAC for RIA, and the coated braided stent may be helpful to further improve the peri-procedure safety. Due to time limit, we didn't cover the FD treatment of RIA today, but we still need further evaluation of FD for ruptured complex aneurysms. And at last, on behalf of Professor Liu Jianmin, and thank you again for giving me the opportunity to share our work and share the experience from China. Thank you very much.
Thanks a lot, Doctor, for this excellent presentation. There is a question from Professor Hauschad. Please unmute yourself and ask the question.
Hauschad, are you there? Perhaps he's.
Hi, John. Hi.
Go ahead. Go ahead.
I just, it's excellent presentation and very nice comprehensive talk on aneurysm coiling and endovascular treatment and good comparison. I just wanted to ask, what is your experience about the web? Do you use webs in certain wide neck aneurysms, or what is your experience? Which is a newer thing which has come.
Okay, thank you, Professor. Because of WIPE has not been widely used in China, so we have just a very limited experience of maybe 10 cases or very small, very limited experience. But it is very useful for the ruptured aneurysm, and we think it is the maybe it is the future, but very limited experience.
What about contour devices?
No, we didn't use the contour. It is maybe has not been used in Shanghai.
It's too expensive. Third thing, I wanted to know if an artery arising from the neck of the aneurysm and which is supplying to the vital structures, how do you manage your endovascular treatment to preserve that artery?
How to use the endovascular treatment for what?
And suppose there is an artery which is arising from the neck of the aneurysm, which is supplying to the vital structure of the brain, which you can't sacrifice even surgically. Like in most of the cases in surgery, we resort to the bypass surgery to prevent the supply to that. How you manage in endovascular treatment?
Okay, it is very difficult to treat these aneurysms with a branch originate from the neck. If we come across with these cases, we always use the several techniques to protect the branches, such as the braided stent. We push the stent into the aneurysm neck and protect the branch, or sometimes we use the open cell stent to protect the branch. And another strategy is about if it is very clear that the rupture point is far from this branch, so we used coils to embolize the aneurysm, especially embolize the rupture point at the first stage, and at the second stage we implanted a stent. Maybe such several techniques, Professor.
Right.
Okay,
thank you. Nice presentation. Thank you.
Okay. Thank you for the nice presentation.